IPL, and I'd go to IgG4-related disease meetings, and they'd say, oh, there's this thing that people keep talking about in Japan and China. It's like kind of like Castleman, kind of like IgG4. We're not really sure where it is. And then last year, when I was on my way here to visit David, I had a pile of papers I was reading, and there are 2 papers that David wrote where basically they said, IPL is Castleman's. The debate settled. And I said to David, like, how long has this been a thing? And he was kind of like, oh, we all kind of knew it. And I was like, oh, wow, I felt really left out of that. And then I talked with John Stone, who's the head of medicine at Harvard, right? Like, that's kind of like being the Michael Jordan of medicine, right? Being the head of medicine at Harvard. And he's the world's expert in IgG4-related disease. And I just spoke to him a few months ago. I said, did you know this is a thing? And he's like, oh, that explains a lot. So, like, you know, like, although we kind of all seem to know these things, it's really important to get the word out because it does explain a lot of things. And then the last thing is that, you know, I didn't think that TAFRO without lymphadenopathy was really a real entity. I thought maybe people were just missing things or whatever, but the Japanese have been talking about TAFRO without lymphadenopathy, and then there was a paper that they published in American Journal of Hematology that David was an author on just a few months ago, where out of 104 patients with TAFRO, 26, or exactly 25%, 1/4 of patients with TAFRO in Japan had no lymphadenopathy, and therefore, by definition, have no Castleman's. So then you have to ask yourself, well, what even is TAFRO then, right? And so this is where I think it goes back to, these are all the things that we're learning about the vasculature and the lymph nodes and that sort of thing. So at the end of the day, to me, the patients don't come to me because they want a super precise diagnosis. They want a treatment that saves their organs and gets them better. And so the better we understand the diagnosis, the easier it is to get to a treatment that works. And I think that's the important thing at the end of the day.
I agree. Sudipto, I don't know if you're interested.
Yeah, I going back to Josh, usually it's not, the disease is not evolving and changing to different forms within the same category. So IMCD NOS is not turning into IPL and then turning into TAFRO. It's usually you didn't catch it all in the beginning. And there are significant phenotypic variations, that is the external manifestation. And I was talking to Luke today, and it's interesting that even depending upon your race and ethnicity, the phenotypic presentation of your condition can significantly vary, and so does your response to treatment. It's anecdotal, it's not been published, but people of Polynesian descent, so Hawaiian people, there is a thought that IMCD happens at a much higher rates in the Hawaiian Polynesian population than in the mainland. Then you go to New Zealand, where you have a lot of Polynesian people. IMCD occurs at a very higher rate, and surprisingly, they have one of the best responses to cetuximab. So I don't think we truly understand the differences at the racial ethnic levels, but starting with an NOS and then TAFRO, probably it was TAFRO to begin with. It's just that there's so much of heterogeneity in the presentation, it didn't get caught in the beginning.
I agree. I was just going to totally agree with you to call it just a comment related to Luke's comments, and that is that Luke seems to always get sent like the most challenging, complicated cases. Every time he calls me, I'm like, oh boy, Luke's calling. This is gonna be a challenging case. He tends to get the most complicated cases that you can imagine from like all over Canada. But what's so important is that he's always so focused on what can I do for this person right now. Like, let's not worry about the category or the subtype or let's just figure out like how can I help this person right now, which I think is just a really good frame of reference. Is obviously I see in Josh and Sudipto, but I just wanted to call that out, that we come up with frameworks and subtypes to help us to think about these things. But the more important thing than like, is it NOS or IPL or this or that, is really just like, how can we help the patient? And I know that your brother's, from what we talked about earlier, is having a really tough time. And so if the frameworks can be helpful for treatment, then that's great. But at some point, you just sort of have to get to like, what can we do to help them? All right, I think we're going to go ahead and get started. Hope everyone had a good lunch. It is so good to see everyone. So happy to all be together. So this is what we call our expert panel. An hour of time for you guys to ask any and all questions on your minds. As I said at the very beginning, we try to keep these questions from being too deeply personal for your specific case. Try to be a little bit more general, because it's just really hard for us to weigh in on exactly what's right for your case. But we welcome any and all questions. We've got an amazing group of panelists. Dr. Josh Brandstadter, who's a physician scientist here at the University of Pennsylvania, where he studies Castleman specifically and also treats Castleman's patients in addition to other rare hyperinflammatory and hematologic illnesses. We've got Dr. Luke Chen, who's come to us from Dalhousie, formerly in Vancouver. You've heard us talk about him. He's the pioneering doctor who used a TNF inhibitor for the first time in Castleman's and has been a wonderful collaborator for many years. And Dr. Sunita Nasta, who is a really world-renowned lymphoma doctor and also Castleman's doctor, who has lots of cowbell, love it, who is just been a dear friend and collaborator for about 10 years now, maybe longer. And she also has, I think, probably one of the biggest lymphoma caseloads I've ever heard of. It's amazing. She treats all of her patients, and they survive for so long that her caseload just gets bigger and bigger. It's awesome. And then I'm also joined by Dr. Sudipto Mukherjee, an amazing physician at Cleveland Clinic. We've been working with Sudipto for years now. I got a chance to collaborate in a few research projects, and we send lots of patients to Cleveland to see Sudipto. So I'm sure a few of you guys see Sudipto clinically. So this is our panel. Madison, should we start with questions that came in ahead of time, or do you want to start with questions in here?
Let's start with questions in here.
Okay, cool. What questions do you guys have for the panel?
Are there cases where Castleman has been cured, where someone was like on rituximab and then after that just stopped any medication and never relapse?
I don't know that we have enough data to tell you that. I think we have patients who have had sustained remissions. We've had patients treated aggressively for IMCD Tafro who got chemotherapy and achieved remission, and they have not needed treatment. But unfortunately, we have a paucity of data. So it depends on how long you're saying. Is it 5 years? Yes, we have patients who are 5 years off of therapy and doing okay. It's just difficult to say. With siltuximab, as you may know, the treatment is ongoing, and we don't have an endpoint per se. I think we've learned to taper doses, and there are patients who achieve really good control. But in this room, there are patients who've had hundreds of doses of siltuximab to keep their disease under control. So it's hard to say what is cure. I think more accurate is control and quality of life.
Yeah, I agree. The only thing I'd add is that the patients that I'm aware of that have sort of gone off therapy and have had, to Sunita's point, a period of remission, who knows how long it will be, have oftentimes gotten intensive chemotherapy along with their rituximab. I can't think of anyone that's gotten rituximab monotherapy that comes to mind that's been off therapy for a long time. And this is for IMCD in particular, that have been doing well for years afterwards.
I'll also add, from the purposes of our registry for Accelerate, we are very interested in the patients who have been able to stop therapy for prolonged periods of time, and we're interested in studying what made them so special that they were able to stop and not have any recurrence of their symptoms.
And we're also studying spacing of therapy. So some people have escalated therapy, meaning that they get siltuximab more frequently than every 3 weeks. Other people have it spread out further, and so we're in the process of trying to better understand what does the frequency of dosing have in terms of an impact on your outcomes.
Honestly, we learn to subdivide the disease more and more because we have enough patients now to say that there are this category or that category, but we're still learning.
What other questions do you guys have?
I think we have some questions from online.
Oh, great.
Hey, everyone. We have a couple of questions regarding international engagement. One question is, how can we adapt the latest Castleman disease research to benefit patients in resource-limited settings like Africa? Are there any efforts to make siltuximab or other effective CD treatments available or affordable in African countries? And have any teams considered collaborating with African research institutions to better understand the unique presentations of CD here?
It's a great question. I'll start and love to hear my colleagues' thoughts. I'm not aware of a concerted effort right now that's going on to increase access to medicine in parts of the world that are considered low resource settings, such as some countries in the continent of Africa. I think that one of the challenges is that it's not just can you make the drug available there, it's are there infusion clinics that are available to get the drug to patients? Is the local government willing to pay for the drug? So there's a lot of challenges that I don't know anyone that's tackling that. I mean, in lymphoma, there's some really great work to get a lot of these drugs to parts of the world where they're not available. I haven't seen the same sort of global health push in IMCD, but I'm interested to hear from you all if you're aware of any.
So Penn, Botswana has had some patients with symptoms that are similar to Castleman's, but it's been difficult to characterize exactly what the pathology is, and so we haven't been able to pin that diagnosis. We did provide access to rituximab within the Penn, Botswana clinic, and the patient did have benefit. It's just difficult to confirm because we weren't able to get the tissue to evaluate.
I think, oh, sorry. Go ahead. Okay. I think this is also where David's, David talks so much about horizontal drug development and vertical drug development, right? Horizontal drug development is when we take what we have and repurpose it for a situation where maybe that's not the FDA-approved indication, but that's what we need to do, not only for rare diseases, right? We repurpose things like adalimumab and rituximab and chemotherapy from lymphoma, the world of lymphoma and myeloma to Castleman's, but I think also in resource-limited settings, we have to be aware of the fact that some of these drugs are going generic, right? Like before siltuximab was available, Lu Zhang used a lot of thalidomide in China, right? It works, right? And thalidomide is relatively inexpensive in China. So I think in contexts where the resources are not as many as we have in North America, we have to be very aggressive about horizontal repurposing.
So I can give you some perspective about patients I have seen from around the world. In South America, actually, in certain countries like Brazil and Chile, you actually have a very good access to siltuximab. I think their system of healthcare is such where the government subsidizes their access. In Asia, especially in Southeast Asia, where majority of the global population lives, cost is a factor, access is a factor. As David was saying, infusional facilities, you really can't set up in a place where, it's not economically viable or feasible to do so. And that is where Lu Zhang from China, their team came up with a TCP regimen. It's a thalidomide, cyclophosphamide, prednisone. These are all drugs borrowed from other diseases, mostly some from leukemias, some from myelomas, and it all goes back to what David has been trying to do here under the every cure thing, which is repurposing the drugs. We have the drugs. We know they have activity. It's just a matter of taking it to other diseases where you can apply, especially in resource crunch settings where it may take time before they get access to siltuximab. So the TCP regimen that's used in China, actually that is the most used treatment for Castleman disease in China, India, Bangladesh, and Sri Lanka, so all the South Asia. And people are doing well. Well, that is the only option they have because it may be a while before they get access to siltuximab. So I think it's while we wait for newer discoveries, we have very cheap, accessible drugs that can be repurposed.
The difficulty is that we don't have controlled clinical trials, so we really rely on patient data from these settings to come back to us so that we know these results. And thankfully, we've gotten some of that data back from China, and now beginning to be from South Asia as well.
Hi, I was curious, what are some of the working hypotheses about the fact that Tafro is more prevalent in younger people, and NOS is more so a middle-aged, older people phenomenon?
Great question. I'll give an initial thought. So patients that, and we didn't talk about this within the IMCD group, but we generally subtype IMCD into patients that have it's called the Tafro syndrome, thrombocytopenia, anasarca, fibrosis, renal dysfunction organomegaly, so TAFRO. Patients get the most sick among the various subtypes of IMCD. I happen to have TAFRO syndrome. The other end of the spectrum is what we call IPL, where patients have high platelet counts, they have high gamma globulin levels, and they tend to be less acutely ill, less aggressively ill, but they still feel really bad. And then we have groups that we call NOS, which is people who don't really fall into either category. So it's a great point from Kai Wen that we see TAFRO almost or among kids, we see TAFRO as really the only presentation of IMCD among kids. In adults, we see both. There's people with TAFRO, people with NOS, people with IPL. And I think my hypothesis would be that the plasma cell-driven sort of IPL picture, in my opinion, appears to be much more similar to something like POEM syndrome or multiple myeloma than TAFRO does. And those types of plasma cell dyscrasias typically don't start appearing until later on in life. So I think the difference is probably it's a similar proportion of TAFRO across the life cycle, but then it's just that this sort of IPL plasmacytic-y thing just starts emerging in older people. That's my hypothesis. I don't know what other people think.
I also think we can correlate somewhat to the numbers with inflammatory syndromes like HLH, which can frequently mimic TAFRO. Or vice versa. We see more HLH in younger patients, so the pediatricians have much more experience with it than we do as adult physicians, but you can see it across the spectrum. So I think there's probably similar aspects to it. Remember that the immune system in children is a lot more plastic, and so may have the flares of the inflammatory syndrome that is HLH or TAFRO much more than adults do.
That's a great point.
I think also one of the unexplored, or one of the frontiers we're just starting to explore is the role of the vasculature. So we tend to focus on what the blood tests show, which is very important, but don't forget that the blood is carried by the blood vessels. And the traditional paradigm of IL-6 being produced in lymph nodes, which then causes the inflammation. That's a big part of the story, but it's clearly not the only part of the story, because if that was what drove Castleman's, then people with UCD, who have the biggest lymph nodes, would have the most inflammation, and people with TAFRO, who have the smallest lymph nodes, would have the least inflammation, but it's the other way around. And so David was recently one of the senior authors on a paper that's mainly from the Japanese group. David and Fritz were on that, that looks at IL-6 from the endothelial cells, so the cells that line the vessels. And that's a fascinating paper. I can't wait to see that one come out, because I think that's a big missing part of the story. So I suspect there's something to do with lymph nodes and vasculature, as you age, that is part of the explanation about why most of the literature in TAFRO is on younger people.
I also don't think that we have the full picture of cytokines that are involved in stimulation. IL-6 has been the most easily identified, but there's probably others that we're just missing completely.
Yep.
And I think, Luke, you do have a point, because in IMCD patients, in TAFRO patients too, you will see the abnormalities in VEGF. It's a vascular endothelial growth factor that has a role in angiogenesis or blood vessel formation, and the numbers are usually abnormal. I am not very certain about the cross connection between VEGF and IL-6 and how it modulates the activity, but the fact that one of the important cytokines or growth factors that are involved in blood vessel formation is altered suggests that there's something going on at that level.
Hello. I'm new to the Castleman's disease world. I was diagnosed in June, and I've tried to read all sorts of literature and information on it. And I understand basically that you start with the lymph node, and then you move essentially to a check the box exercise where you have certain lab scores and night sweats and all that kind of stuff. And then makes sense so far. And then I come to my actual symptoms, and I talk to people here, and they say everybody here has different symptoms. Mm-hmm. So I'm curious of linkages. One of the graphs they showed today actually said so many % of people with MCD have peripheral neuropathies, for example. But I haven't seen a lot of other things. So I'm curious about linkages to central nervous system type neurologies, amyloidosis type things? Are there other, 30%, 10%, 20% of the people have linkages to this where the symptoms appear perhaps inflammation driven in other parts or specific parts of your body?
I just seem to be talking a lot. The issue with Castleman's is very much that we have to rule out other entities. So when you do the exercise of ruling out other entities, it tends to decrease the population of patients who have Castleman's who have a particular symptom. So it's hard to say, oh yes, there is a group of patients who have this particular manifestation of Castleman's. As we get larger populations, we'll be able to do that. And I do think that there will be crosstalk between Castleman and other inflammatory disorders. But right now, if you have one of those other inflammatory disorders, it tends to rule out Castleman's.
Yeah, the 2017 diagnostic consensus criteria advanced our field so far in providing a very clear definition about about how to establish a Castleman disease diagnosis. But still, even now in 2025, when we look at unicentric Castleman, oligocentric Castleman, multicentric Castleman of all of the different subtypes, IPL, NOS, and TAFRO, we still have a disease that's largely syndromic in terms of its definition, and we can ultimately put everyone under the banner of big lymph nodes that look a certain way under the microscope to I think a more detailed biological characterization is necessary in order to provide a more precise definition about what all these different subtypes of Castleman are, and that can then help to link or disassociate from the other diseases, because otherwise we're left with this position where we have to establish the inclusion criteria, but then, as Dr. Nasta was saying, also establish that it's not anything else.
Yeah, I totally agree. And I'll give an example. Historically, with multicentric Castleman disease, if you read papers about Castleman's, they would say that there is a significantly increased risk of lymphoma in patients with multicentric Castleman disease. We've been studying Castleman's now for about 12 or 13 years, and we've gone through hundreds of patients worth of data and lots of information. And what we've pieced together is that it appears that there's not a really substantial increased risk of lymphoma. What was being observed in the past was people had lymphoma and they had a lymph node taken out next to their lymphoma, or even a lymph node that had lymphoma in it, and it looked like Castleman disease. And so the case reports and the doctor was saying this person has Castleman's and lymphoma, or they had Castleman and they got lymphoma. No, they just always had lymphoma, and the lymph nodes looked like Castleman disease, but they didn't have Castleman disease. And I think it's an important finding. That's a very sort of black and white, like lymphoma or Castleman's, but there are also a lot of autoimmune diseases where patients' lymph nodes can look like Castleman disease, but actually they have some other process that's going on. You asked specifically around CNS-related symptoms. We don't typically see too many CNS-related symptoms. We see peripheral neuropathy. Sometimes people have sensory neuropathy, sometimes motor neuropathy, but it's less common to have central CNS issues in Castleman's. But again, as everyone said, Castleman's is very heterogeneous, and that's not a by-the-book rule, and every one of us, can present differently.
I think we maybe have some more online questions too. Well, I get to...
I also have a pre-submitted question that we could ask.
Okay.
This patient is asking, how do you know when it's time to conclude siltuximab when it's not working? How long is too long, and what would the criteria be to determine whether another option, maybe sirolimus, is worth considering?
I like to give at least 3 to 6 months of siltuximab before I abandon it, just because I think that it can take some time for the symptom improvement to manifest in a true quality of life benefit. The times I stop sooner is when there are side effects from the siltuximab that outweigh the benefit being received. So if people are having severe infusion reactions or infections or other problems related to siltuximab, I may stop sooner than that. But usually I give between 3 and 6 months of therapy before I abandon. Or if they're showing changes in their profiles, such as increasing lymphadenopathy or increasing symptoms on siltuximab, that might be a time to change.
Yeah, I totally agree. And just following along to Sunita's second point about increasing symptoms, if you are a patient with severe IMCD, so you're very sick, typically you would be in the hospital, you wouldn't be able to be here at the summit. If you're in the hospital and you're on siltuximab and you are progressing despite the siltuximab, to Sunita's point, you really should be thinking about adding on chemotherapy, because we know that this is a deadly condition. It can be deadly, and that if you sort of wait too long to see if the siltuximab is going to kick in when you're in the hospital, that's not the right move. But exactly, if you're out of the hospital, that is the time to see if it works, and to have the 3 to 6 months. But if you're in the hospital, it shouldn't be a watch and wait sort of thing.
Yeah, and to extend David's point, I would say for patients who are having severe manifestations of their disease through starting siltuximab, so you're in the hospital, you're having organ dysfunction, it's getting worse and worse even though you are on siltuximab, you may require chemotherapy, but at the same time I would not call you refractory to siltuximab. I would continue the siltuximab as a maintenance agent after the chemotherapy and give it a better chance to see whether it was working for you once you've used the chemotherapy to bring back your disease into a more controllable position without the severe manifestations.
And the difficulty with outside hospitals that don't see a lot of severe Castleman's disease is they may not be dosing you with enough siltuximab to actually be showing the benefit. We've noted that sometimes you need to give more in that acute setting in combination with chemo to get that patient stable.
I think what I have experienced is there is a tendency to panic and get desperate, and that leads very frequently to premature discontinuation. So for example, you have a patient in the hospital who is in the ICU on a ventilator and is on dialysis and on tube feeding, and you start the siltuximab and you add initially some chemotherapy and steroids to rapidly control the symptoms. You have to understand those organ dysfunction will not get better in a day. They're going to take time. And it would be a mistake to discontinue the treatment soon enough because you did not give the treatment time enough to do its thing. Usually, and I know I talked to a few of you today, there are examples here who had ascites, who were on dialysis, and now they are not. So that tells you that if you start the treatment, you have to be patient. And unless the reasons to discontinue siltuximab would be just what Dr. Nasta said, you got better, everything got better, your symptoms got better, your labs became normal, and now the symptoms are coming back, the lymph nodes are growing back, your inflammatory markers are going up despite being on siltuximab. That would be a time when you reconsider whether siltuximab is working or not, and that may require additional investigation at the time.
Yeah, just add a comment that, a lot of the sort of being patient is when you are heading in the right direction. If you're very sick with tafro, your doctor should be all over that. I check blood work every 6 hours on someone with tafro. I make sure that the CRP is coming down. The CRP is your friend if you have any type of Castleman's with inflammation. It's simple, it's inexpensive, it comes back quickly. If it's coming down, you're probably getting better. If I give someone siltuximab and 6 hours later the CRP is not coming down, then if they're very bad, then I might just throw other things at them, because it's very hard to hurt someone with 1 dose of tocilizumab or 1 dose of adalimumab. My own feeling is if you're dealing with very bad tafro, get it under control. Figure out what you need to keep them under control later after the dust settles, but don't be afraid to throw in more things to get them better.
The outpatient situation is so different as well. Remember that the approval for siltuximab is based on symptom improvement, right? So the original studies were a little vague on the timing of when those symptoms improved, because some patients got improvement within a month and some people took a lot longer. So in the outpatient setting, where patients are not needing hospitalization or needing acute care, some patients is required to have the drug work.
And I think this is a fairly sophisticated audience, but I'll say this because, my gosh, how many different doctors we knew were confused on this point. The serum IL-6 levels are not a reliable indicator of your disease when you are on siltuximab. The medication falsely elevates the IL-6 level, so that we know heard of so many patients who thought their disease was getting worse on siltuximab, even if they were feeling better. All their other numbers were getting better, and just the siltuximab level went high, and that's because of the medication itself interferes with the measurement of IL-6 levels.
Can we take IL-6 out of the next set of the guidelines? It's just very confusing.
It was pretty low. It wasn't required, but yes. And I'll just state, this is such a great point that Josh and also Luke are bringing up. Just restate. Once you get started on siltuximab or tocilizumab, don't measure IL-6 levels, and if your doctor measures them, don't pay attention to them. If your doctor tells you to do anything, tell them to talk to me. As Josh said, they're completely uninformative, and I've gotten so many calls over the years from doctors saying, my patient is doing great, but they're relapsing. And I'm like, what do you mean? You can't be doing great. Well, they're doing great, but their IL-6 levels are going up, so we're going to give them chemotherapy, or we're going to give them a bone marrow transplant. We're going to, no. IL-6 levels will go up while you're on siltuximab or tocilizumab as a result of the test, just as Josh mentioned. It's not, your IL-6 levels are not actually causing problems when you're on siltuximab or toci. So please don't let your doctors do that. So that's what we don't want the doctors to do. What we do want you and your doctors to do is to, if you have IMCD in particular, is to look at things like albumin, C-reactive protein, creatinine, platelet counts. These are laboratory abnormalities. If I didn't say hemoglobin, that are just reliable. They're helpful. Sometimes they can bounce one way or the other, but if you see all of them going in the wrong direction or all of them going in the right direction, those are much, much more effective than something like IL-6 levels.
And the other thing that I always know with our Castleman's patients when I'm talking to outside physicians is it's sort of like it being in the middle of a code blue, right? What they tell all interns to do when they first encounter a patient who's in a code blue is to check your own pulse. And the same with this, like, you can't panic. You have to be thoughtful and compulsive about looking at all aspects of the patient's care before you make changes.
Yep.
I appreciate your taking my question. I haven't been here before, so it's just been so enlightening for me. My husband and I are actually here from Phoenix. Off point, my son David, who is suffering with this dreadful disease, was born at the Hospital of University of Pennsylvania 47 years ago, and my daughter 50 years ago. So we are sort of coming home again. My quick question was, can you mention or speak at all about pain management? My son is going through writhing pain. We don't know what to do. We know he has these terrible infections. He's been in the hospital 3 or 4 times in the past 6 months. But, over and above that, the writhing pain that he is in, we can't seem to get anyone in Phoenix to, give him anything for pain, or it's just really a hard thing to watch him go through.
Thank you so much for bringing attention to the issue of pain with Castleman disease. I think the thing that I've been most chastened about with pain and Castleman disease is to make sure that the patient may not have particularly if they're having active diseases, to make sure they don't have a condition called calciphylaxis, where they have a shower of clots to the skin that can be quite painful and sometimes a skin biopsy will be helpful for the management of that.
Yeah, hopefully, Sunita.
And neuropathic pain can be very difficult to manage, so understanding the type of pain is pretty critical to defining the right treatment. And various different types of Castlemans can have levels of neuropathy. For example, the IPL ones that mimic multiple myeloma or POEMs can have very painful peripheral neuropathy, and close coordination with a neurologist who does peripheral neuropathy work can be helpful to find the right pain management for that.
I agree, and what I'm hearing here from my colleagues is that trying to diagnose the source of the pain is going to be really important here. If it's calciphylaxis related, if it's neuropathy related to something like POEM syndrome, you want to know that because you're going to be able to treat that differently. The kind of pain that I really struggled with when I was really sick with my tafro was related to the fluid accumulation. So because I gained about 100 pounds of fluid over a couple weeks, that meant that it was really painful because there was sort of stretching of everything, and certainly the sacs around your heart, your lungs. It's really painful when they stretch like that. So that was sort of one sort of pain. We sometimes will hear people tell us about pain in their lymph nodes in Castleman disease, and that's just not typically what we have in Castleman. So we have big lymph nodes; they're not typically painful. And when I hear someone has a painful lymph node, I worry maybe they have something else. Maybe they're having an infection due to something else, because we just usually, they might be big, but they're usually not tender in Castleman disease. So you just want to sort of like try to pay attention, like what could be a source for it? Can you share like how localized, is it in one spot or is it all over? Or another thing, is it joint pain? Can you share a little bit more? I mean, I know that we're not supposed to be doing like direct patient stuff. Open wounds, yeah. So that's going to be a whole nother set of challenges.
I do believe he has nerve damage in his feet. He cannot. His feet are actually deformed. They claw in like this, and he just has no. I can't even describe it. I wrote it down, but now I can't. Now I can't find it. But it is definitely neuropathic in his feet.
Yeah, the hope and what we've all seen on this panel is that when someone has as many challenges as your son is going through, we found that if you can get the Castleman disease under control, if you can find the right drug for the Castleman disease, then we tend to see the other stuff start to improve. I mean, it's actually pretty remarkable, in my opinion, how much we Castleman's patients can recover if you can just hit IL-6 or mTOR or B cells or whatever that thing is that's really the problem. So I don't know how well your son's disease is controlled, but you really should connect with Madison if you haven't as of yet to see if we can get.
I don't think we have
see if we
any
can
experts in
get
Phoenix.
him to an expert. Yeah, maybe we can get to an expert somewhere else.
Yeah, and,
Andrew Goodman's going to Phoenix.
Oh, really?
Yes.
Oh, nice. Okay,
So-
a really great doctor from San Diego is apparently going to Phoenix, so we can connect you with him. Great, I didn't know that.
For a TAFRO patient who is presenting with normal labs, how often do you recommend that they get like scanned? Are they supposed to do like yearly scans, or what should we be looking out for as far as like the way our doctor's doing follow-up?
So you're saying normal labs now, but they were really sick when they had TAFRO,
Yeah,
right? Okay.
yeah. My husband, he was in
Yes.
the hospital for 40 days and
Wow.
dialysis and all the good
Goodness.
stuff. And they threw a cocktail at him, and he's here today. He's
Great.
doing good.
Great.
But I just want to make sure we're this was December 2023, and he's been great. But I just want to make sure that we're being proactive. And I think he's had one PET scan since then. So I don't know if there's like a protocol, like, a yearly scan, or is it just symptom based, or?
I think it's just so difficult. Like, it depends on what the starting symptoms were. For my TAFRO patients, I've tended to see them quarterly, and probably the first couple of years scan 1 to 2 times a year. But really, it's what we call category B data, in that we don't have strict guidelines on what to do, and it's frequently led by symptoms, and frequently we treat ourselves as physicians to make ourselves feel better and scan, but usually that's not going to be all that revealing.
Yeah, the only thing I'd add is that so with something like Tafro, I've had 5 flares of this disease of Tafro, and the flares come on within a course of like days, like from like I'm totally healthy, and then within days. Thankfully, it's been 11 years since my last one. So the likelihood that your PET scan or CT scan is going to just so happen to capture like the onset of Tafro, if you're doing it even once or twice a year, even if you're doing it 10 times a year, it's just unlikely the scan's going to catch anything early. So I don't think it's particularly useful for a Tafro patient. But what is really useful, as was said, is really to pay attention to your symptoms. So remember, I know we don't want to put it out of our mind, but try to remember how you felt before you first ended up in the hospital. Like, what were those symptoms? I shared during an earlier session that however you presented the first time, whatever those symptoms were and whatever those blood tests were that were abnormal for you, so maybe it was alkaline phosphatase and you probably had a low albumin and a low platelet count, like know what those handful of things that were really bad really early were for you, because Castleman's is different across all of us, but we find that it's very consistent within each of us, meaning that like we may all seem a little different with each of our flares, but what we see from the data is that each of our relapses is consistently just like the previous one. So if you know what your symptoms were like, if you know what your abnormal lab tests were like, if and when it comes back, you're going to have those same things. The other thing I'll say is that means that if imaging isn't that helpful, that means it puts a lot of onus on us as patients to pay attention to our symptoms. And I know we don't want to do that because we'd rather like go back to our lives and like not worry about our symptoms. And for some people it can create real anxiety, like if you're always worried about your symptoms, and that's actually a problem. We don't want anxiety, but we want to find that middle ground where you are paying attention to, do I feel more tired than usual? And if it's one day or it's 1 week, don't worry about it. But if it's a couple weeks and it's worse than you felt before, or you notice the enlarged lymph nodes, it's important for us as patients to really take ownership of like, what are my symptoms? My doctor's gonna do their blood tests on me. They'll do a scan. The scan's probably not gonna be very helpful. The blood test, also unlikely that it's gonna be helpful because it's more likely that I'm gonna have a relapse on a day where I'm not getting a blood draw than on the few days where I am getting a blood draw. So it's really important for us to really take ownership of knowing what our symptoms are. And the other thing I'll share, and I joked about this last year at the summit, but I wear something called the Whoop, and I have no affiliation with the Whoop, but other than my love for it. But the Whoop constantly tracks all of my vital signs. So my heart rate variability, your oxygen, your respiratory rate, your body temperature, and it basically gives you a score every morning when you wake up to say like how healthy you are. And I've only been wearing it for a few years, so it's never detected a Castleman's flare, which I'm really happy about. But it's a way to sort of see like, am I in a good state of health? And I think that things like this, or just paying attention to how you feel, writing in a journal, I think are important things that those of us with IMCD Tafro in particular should do.
Josh and I also came up with the 3 Ps for patients with Castleman's, which is it puzzling, is it persistent, and is it progressive? So I always say, is your nose itching? Okay, if it itches one day, no problem. If it's itching every day for a month, then maybe you need to look at it.
More questions online, maybe?
I could do a pre-submitted one. I have a question. Can you go on one of the weight loss injections, Ozempic, Wegovy, Mounjaro, if you're having siltuximab infusions?
I can only speak to an anecdote. I do have one patient who is on it at Tosi as well as Wegovy, and she's doing great. But that's one patient.
From what I know, it's a limited. I have 3 patients who are on Mounjaro and siltuximab. So far, we have not seen any drug-drug interaction.
Great. And I'll just comment on weight with that as well. I think some of you have heard of, or may have heard of weight gain associated with siltuximab. And so there's 2 pieces to that. One of them is that we lose a lot of weight before we get sick with Castleman disease through something called cachexia, and it's related to actually our disease. So getting our disease under control, we will gain weight because like we're no longer in this state of hyperinflammation. And then the other is that there likely appears to be some sort of actual additive weight gain that comes with it. So just want to comment on that. Andrew?
So, what was it 2 years now? Yeah. 2 years ago, I went on the Mounjaro. And of course, you start out at, I think it's 2.5, then 5, and 10 milligrams. After 11 months, the prescription ran out, and the insurance didn't want to do it again. So I was only on it a short period of time. But by the end of that, one of the things we did notice was it spikes your testosterone. Mine was over 2,000. And now it started to come back down. But I did lose 55 pounds,
Wow.
which has helped tremendously. But my primary care was handling that. And we were looking at possibly putting me on something else because my A1C, when I started the siltuximab, I did put on a good bit of weight. I was up to 280. And my A1C had started to creep up. And when it got to a certain point, he wanted to make sure we jumped on it pretty soon. So instead of going a lot of oral meds and trying different things, he got it okayed and put me on the Mounjaro. And we knew it was going to be a short-term fix. But I've managed to keep the 50 pounds off.
That's amazing.
For a year now.
That's awesome.
But yeah, you got to be careful, and everybody reacts different on it. But with the the siltuximab works great for me. But yeah, the Mounjaro worked great. Luckily, I didn't have any of the serious side effects that you're seeing that pop up now. It seems like every week there's a new one. But just recently they did have CDC mentioned that it spikes your testosterone. And they're starting to see that more and more. So, and all the fun things that go along with spiking testosterone, like, 15-year-old kid having acne again. That's always good. And a little bit of the rage thing. And
Thanks, Steve.
Sorry, I have to run.
Thank you. Woo!
We can do another online question if in the meantime. Have there been more studies regarding the use of siltuximab during pregnancy or just pregnancy of patients with Castleman disease?
Josh, you want to take that one?
Yes, the Accelerate registry is currently trying to learn more about how patients with Castleman disease who are on therapy or off therapy have been doing with all issues related to fertility, conception, and pregnancy, because this is, I would say, a big problem that we have where we do not know or have very clear answers about how patients do on therapy and how to best make therapy decisions to control your disease while you are pregnant and in the early postnatal period while breastfeeding as well. We do know that these monoclonal antibody drugs, tocilizumab, siltuximab, can cross the maternal placental barrier. We do know that they can be present in breast milk. What we have not observed, based on other patients from other diseases who are treated with siltuximab or tocilizumab, is that there are any adverse consequences for the developing fetus or baby for patients who continue their therapies. But we currently suggest a informed, shared decision-making between the patient and the provider about how to manage siltuximab or tocilizumab or any IMCD therapy while the patient is trying to become pregnant, becomes pregnant, and chooses about breastfeeding. So please, if you have had any experience in this issue, please let someone from our team know this so we can make sure you are enrolled in our study of this.
Yeah, I agree. And the only other thing I'd add is that, even just recently, there was a healthy baby born to someone who was on siltuximab during their first trimester. And so there was an attempt to then spread out and then eventually discontinue. Just because, to Josh's point, we just don't really know all that much. The cases that we are aware of, we have not seen any significant issues, but we just don't know. And so, so if you are, just as Josh said, if you're pregnant, thinking about becoming pregnant, or if you're not, letting us know and being a part of this research study is one thing, but also letting us know so we can potentially provide some thoughts on clinical care. We don't have all the answers at all. We really have a lot more questions than answers, but happy to be thoughtful with you all on how to think about navigating that for you.
We're getting a lot of questions online about symptoms, side effects, and using other medications. So I'll try to ask these in sets. So the first set of questions, 1, does it make sense for an IMCD patient to get vaccinated? And 2, is it okay to take any of the weight loss injections like GLP-1s if you are using IV siltuximab?
I'm happy to talk to both of them. So we have no reason to believe that patients with Castleman's would have any sort of different response to vaccines in a negative or positive way than someone who does not have Castleman disease. What we did do a small study looking into this with COVID, and we found that patients with Castleman's who were on Castleman's drugs who got the COVID vaccine had a similar robust response to people who didn't have Castleman's. And we haven't seen any issues with other sort of vaccines otherwise. I mean, of course, most people that get Castleman's, it's years after they've gotten, their vaccines at young ages. And so maybe we don't have a great data set for it, but we haven't seen anything to bring any concerns. And then in terms of GLP-1s, we heard about anecdotally a few cases that GLP-1s were helpful, but I think still early days.
I don't know if you have this problem as much in the States, but we're getting a lot of measles in Atlantic Canada. And make sure you're up to date with your measles vaccination, because that is a problem if you get measles.
I don't know, David, but I think in certain institutions, especially like at the Cleveland Clinic, they did a risk-benefit analysis with the infectious disease doctors and the immunology people and the hem-onc doctors. And we typically, you can get all the vaccinations you need, just like any normal person. But we typically try to avoid it, especially on the day you get the siltuximab, or preferably if you can avoid it on the week you get the siltuximab. Obviously, if somebody's getting chemotherapy, you don't want to do it in the middle of chemotherapy. You want to do it after that. But just as a cautionary approach, I don't think there's a whole lot of data to support that. But that's how some places are doing.
I think it makes sense conceptually, right? So a lot of the drugs we take, whether it's siltuximab or in my case sirolimus, these suppress your immune response. That's like what they are intended to do, and as a result, so if you're going to get a vaccine, you're going to have a less robust immune response. And so I think that there's that one concern, which Sudipto it's a great point, is how good are you going to respond to the vaccine if you've got a suppressed response? The other is if you had some sort of bad reaction on the day of your infusion, then you don't really know, is it the infusion or is it the vaccine? So I think it's probably good to just separate these things in time.
I can keep going. So a couple of more questions about side effects. Could low average body temperature be a side effect from siltuximab? And given that, is it okay to take a short pause from siltuximab if the side effects become unbearable?
I think I could see a conceptual linkage to body temperature being slightly lower. I mean, I think we all of us, or all the people in the room who don't have Castleman's, I can't say all of us because I do, but for those of you that don't have Castleman disease, you have low levels of interleukin-6 that are in your blood, and that's good for your immune response. It also is likely going to keep your body temperature at some sort of appropriate rate. And I guess if you completely block IL-6, then maybe it could go a little bit lower. I'd never heard that, but I can conceptually see how that might be the case. And then the second question, Anush, what was it again?
Is it okay to take a short pause from siltuximab if the side effects become unbearable?
So I would say if the side effects are unbearable, that might be an indication that that is not the right medicine for you. For siltuximab, the nice thing is that it is not the only anti-IL-6 medication. And we've seen, I would say, a reasonable number of patients who were able to move between anti-IL-6 medications when they've had one that was efficacious but in having an intolerable side effect for. And so that might be the best move because there is a slightly different side effect profile between the medications so that you may be able to retain the efficacy, it's working for you, while losing the side effect.
Just remembered something. Our son has a very, very low testosterone level. Is that something that would be related to the Castlemans, in your opinion?
We haven't looked at it in particular. I suspect that data is in Accelerate. I mean, I don't think we've ever looked at it. I'm looking for Bridget if we ever. I mean, so just so you know, when you give your records to us in Accelerate, there are somewhere between 50 and 70 lab tests that if they're entered, if they're anywhere, if our team sees them, then they enter them in to the registry. And then there's another 100 or 500 different lab tests that you might have had that aren't part of our required to be entered, but if they're abnormal, then we enter them into the registry. And so, yeah, if there's a lot of abnormal testosterone levels, then we would have captured them. Of course, not everyone gets testosterone measured, so we don't have a good what's called denominator of research. In research, you like to know, did everyone get it done, and then out of everyone, who has it that's abnormal? In this case, we would only have if it was abnormal, but certainly something we could look into. I don't think that'd be too difficult.
Yeah, wanted to find out, is there any relationship between IMCD or siltuximab treatment that affects your heartbeat? At times, they've measured my heartbeat down to 32 beats per minute in the evening.
That doesn't sound like a directly siltuximab related thing. That sounds like something you should see an internist or a cardiologist about.
I've been to the cardiologist and everything's fine.
You're not on the heart med? Nope.
Those leaves you were telling me about earlier that you've been taking. I mean, you did tell me about it over lunch, and there's some leaves that do some stuff, so I don't know.
Has any funding been cut for the CDC and research given the government cutbacks? I know NIH and other grant research reductions have been made.
Yeah, so within our group here at the Castle, we are funded primarily by NIH and the FDA. Those are our two biggest grant makers. And thus far, I'm going to knock on some wood, thus far, those grants have not been negatively affected. We had to submit at the end of every year, you submit a progress report for everything you accomplished, and then that opens up funding for the following year. And we accomplished a lot in the last year, and certainly throughout the course of these grants. Submitted it, and we got the full amount of funding for the next year. So far, so good. We've heard of colleagues that have not had that be the case, where either percentages of funding or all of the funding is getting taken away. So far, so good, but I'm going to knock on some wood because, we don't know.
Yeah, I just have a statement to address his heartbeat, his pulse. I have a pulse of less than 40 at times, and I don't have Castleman's or take siltuximab.
Or leaves.
Or leaves. So it can be due to other medications. I take migraine medication that makes it low. But my doctor said if it doesn't look like I'm huffing and puffing and exhausted, I'm okay at that.
All right, if that.
I have a question about the different IMCD classifications, like how mutually exclusive they are. Is it possible that a patient that was diagnosed with IMCD, the non-otherwise specified, then suddenly transitions to TAFRO, or is that like
Great question. The intention of the NOS is really just to say that it's not one of the other ones. So we do think of them as being mutually exclusive. So like if you have TAFRO, you got TAFRO. NOS is sort of our place for like, they don't seem to fit into one of these two big categories. Is it the case that that it's not you who has Castleman, your brother, is the case that he presented the first time not as TAFRO and then he sort of showed up as TAFRO? Is that kind of? Interesting. Wow. Yeah, we just I don't know if we've ever seen that before. I don't know.
I think, as you said earlier, usually the Castleman that you start with is the Castleman you keep getting. I will say, though, sometimes there can be a subtler presentation where it's maybe not clearly TAFRO or NOS. Maybe the degree of thrombocytopenia isn't quite as prominent. So it's possible that we use these categories, but it's always a continuum, and you could be somewhere in between.
Yeah, I mean, I think one of the sorry, go ahead. Okay, well, I mean, one of the great things about this group is that people being involved in research in Castleman's is really driving forward our understanding of the disease. As David said at the very beginning, it's a hard disease to pin down, and the better we can classify it, the more we understand. So I'll tell you three kind of funny stories. One is, like, I kind of always thought that multicentric Castleman disease is always symptomatic and always needs treatment, but then Lu Zhang wrote this paper that there's a subset of people with asymptomatic MCD, and that was just published last year, so that kind of blew my mind. But it explained a lot of things because I had some people with multicentric Castleman disease who really, seemed fine. The second thing is that, I also have an interest in something called IgG4-related disease, which overlaps a lot with